She's going back. It's okay. Okay.
Good morning, all specialists, fellow MOs, household. Today, my group will be presenting on Surviving Sepsis Campaign Guidelines 2021 and update. So this is the content of my presentation. I'll begin with introduction, types of statement and evidence, and subcategories. So for introduction, sepsis is a life-threatening organ dysfunction caused by a dysregulated host response to infection. As we all know, it's a major healthcare problem impacting millions of people each year, killing between 1 in 3 and 1 in 6 of those it affects. Therefore, early identification and appropriate management in the initial hours in patients with sepsis and septic shock improve outcomes. The new Surviving Sepsis Campaign Guidelines 2021 was released in October 2021. It provides guidance for the clinician caring for adult patients with sepsis or septic shock. So this is the types of statement and evidence that will be used in my presentation, and it is also used in the guideline as well. So this white star with a blue background is a best practice statement. Question mark is no recommendation. Green, the one with the green background is strong recommendation for. The one with red background is recommendation against. One exclamation mark is weak recommendation. 2 exclamation marks strong recommendation. This one, the quality of evidence, 4 bars filled, high quality evidence, 3 out of 4 bars moderate quality, 2 out of 4 low quality evidence, and 1 out of 4 bars very low quality evidence. This arrow pointing up is an upgrade from the previous 2016 guideline, and the arrow pointing down is a downgrade from the 2016 guideline. And the ones with the blue background is a new change recommendation. The one with the white background is the same as the previous 2016 guideline. So basically there are 6 subcategories in this guideline, but I'll be only focusing on the first 5, which are relevant to our department. So for the first subcategory, screening and initial resuscitation. Recommendation number 1, for hospitals and healthcare system, we recommend using a performance improvement program for sepsis, including sepsis screening for acutely ill, high-risk patients and standard operating procedures for treatment. It is a strong recommendation with moderate quality of evidence for screening and very low quality of evidence for standard operating procedures. So performance improvement programs generally consist of sepsis screening, education, measurements of sepsis bundle performance, and patient outcomes. These programs were associated with better adherence to sepsis bundles along with a reduction in mortality. Sepsis screening tools, for example, like QSOFA, SOFA, MUSE, and MUSE, they are designed to promote early identification of sepsis. And SOPs are like a standard set of practices that specify a preferred response to specific clinical circumstances. For example, the sepsis bundle. Mortality was found to be lower in hospitals with high compliance in achieving the sepsis bundle successfully. So as a summary, this is the our 1 bundle. Number 1, measure lactate level, and we measure it if the initial lactate is elevated more than 2 millimoles per liter. The second one is to obtain blood cultures before administering antibiotics. Then administer broad spectrum antibiotics. Begin rapid administration of 30 ml per kilogram of crystalloid for hypotension or lactate more than 4. And apply vasopressors if hypotensive during or after fluid resuscitation to maintain an MAP of more than 65 mm mercury. Next, we recommend against using QSOFA compared to SIRS, NEWS, or MUSE as a single screening tool for sepsis or septic shock. Because they have found that QSOFA has poor sensitivity. Number 3, for adults suspected of having sepsis, we suggest measuring blood lactate. So for initial resuscitation, sepsis and septic shock are medical emergencies, and we recommend that treatment and resuscitation begin immediately. For patients with sepsis-induced hypoperfusion or septic shock, we suggest that at least 30 ml per kilogram of IV crystalloid fluid should be given within the first 3 hours of resuscitation. Studies have shown that failure to receive 30 ml per kilogram of crystalloids within the 3 hours of sepsis onset is associated with increased in-hospital mortality, delayed resolution of hypotension, increased length of ICU stay, irrespective of comorbidities, including ESRF and heart failure. Therefore, when managing septic patients, it's important to perform a detailed initial assessment and to re-evaluate patients' response to treatment. Next, for adult with sepsis or septic shock, we suggest using dynamic measures to guide fluid resuscitation over physical examination or static parameters alone. Dynamic parameters includes response to passive leg raise of fluid bolus, using stroke volume variation or pulse pressure variation and echocardiography. They have better diagnostic accuracy at predicting fluid responsiveness. Next, for adult with sepsis or septic shock, we suggest guiding resuscitation to decrease serum lactate in patients with elevated lactate level over not using serum lactate. For adults with septic shock, we suggest using CRT to guide resuscitation as an adjunct to other measures of perfusion. The Andromeda shock trial evaluated resuscitation using CRT and found it to be more effective than the resuscitation strategy using lactate in reducing organ dysfunction. Next, for mean arterial pressure, for adults with septic shock on vasopressors, we recommend an initial target MAP of 65 mmHg over higher MAP targets. An RCT evaluating patients in septic shock randomized to MAP targets of 65 to 70 versus 80 to 85 found no difference in mortality. And there was also higher rates of atrial fibrillation in the group randomized to the higher MAP target. Admission to intensive care. For adults with sepsis or septic shock who require an ICU admission, we suggest admitting the patient to the ICU within 6 hours. Next subcategory, infection. So for the diagnosis of infection, for adults with suspected sepsis or septic shock but unconfirmed infection, we recommend continuously evaluating and searching for alternative diagnosis and discontinuing empiric antimicrobials if an alternative cause of illness is demonstrated or strongly suspected. Time to antibiotics. For adults with possible septic shock or high likelihood of sepsis, we recommend administering antimicrobials immediately, ideally within 1 hour of recognition. Low quality of evidence for septic shock, but very low quality of evidence for sepsis without shock. For adults with possible sepsis without shock, we recommend rapid assessment of the likelihood of infectious versus non-infectious causes of acute illness. The mortality reduction associated with early antimicrobials appears to be strongest in patients with septic shock. For adults with possible sepsis without shock, we suggest a time-limited course of rapid investigation, and if concern for infection persists, the administration of antimicrobials within 3 hours from the time when sepsis was first recognized. So in summary, if shock is present, if sepsis is definite or probable or possible, we administer antimicrobials immediately, ideally within 1 hour of recognition. But if shock is absent, we only administer antimicrobials immediately within 1 hour if sepsis is definite or probable. If sepsis is possible, they recommend a rapid assessment of infectious versus non-infectious causes of acute illness and only to administer antimicrobials within 3 hours if concern for infection persists. For adults with a low likelihood of infection and without shock, we suggest deferring antimicrobials while continuing to closely monitor the patient. Biomarkers to start antibiotics. For adults with suspected sepsis or septic shock, we suggest against using procalcitonin plus clinical evaluation to decide when to start antimicrobials as compared to clinical evaluation alone. Antimicrobial choice. For adults with sepsis or septic shock and high risk of MRSA, we recommend using empiric antimicrobials with MRSA coverage over using antimicrobials without MRSA coverage. And for adults with sepsis or septic shock at low risk of MRSA, we suggest against using empiric antimicrobials with MRSA coverage as compared with using antimicrobials without MRSA coverage. For adults with sepsis or septic shock and high risk of multi-drug resistant organisms, we suggest using 2 antimicrobials with gram-negative coverage for empiric treatment over 1 gram-negative agent. For adults with sepsis or septic shock and low risk of multi-drug resistant organisms, we suggest against using 2 gram-negative agents for empiric treatment as compared to 1 gram-negative agent. For adults with sepsis or septic shock, we suggest against using double gram-negative coverage once the causative pathogen and susceptibilities are known. Antifungal therapy. For adults with sepsis or septic shock and high risk of fungal infection, we suggest using empiric antifungal therapy over no antifungal therapy. For adults with sepsis or septic shock at low risk of fungal infection, we suggest against empiric use of antifungal therapy.
Yeah, printing out.
Okay. For antiviral therapy, we make no recommendation on the use of antiviral agents. For adults with sepsis or septic shock, we suggest using prolonged infusion of beta-lactams for maintenance after an initial bolus over conventional bolus infusion. For adults with sepsis or septic shock, we recommend optimizing dosing strategies of antimicrobials based on accepted pharmacokinetic or pharmacodynamic principles and specific drug properties. For adults with sepsis or septic shock, we recommend rapidly identifying or excluding a specific anatomical diagnosis of infection that requires emergent source control and implementing any required source control intervention as soon as medically and logistically practical. For adults with sepsis or septic shock, we recommend prompt removal of intravascular access devices that are a possible source of sepsis or septic shock after other vascular access has been established. For adults with sepsis or septic shock, we suggest daily assessment for de-escalation of antimicrobials over using fixed durations of therapy without daily reassessment for de-escalation. For adults with an initial diagnosis of sepsis or septic shock and adequate source control, we suggest using shorter over longer duration of antimicrobial therapy. For adults with an initial diagnosis of sepsis or septic shock and an adequate source control where an optimal duration of therapy is unclear, we suggest using procalcitonin and clinical evaluation to decide when to discontinue antimicrobials over clinical evaluation alone. Third subcategory, hemodynamic management. For adults with sepsis or septic shock, we recommend using crystalloids as first-line fluid for resuscitation. For adults with sepsis or septic shock, we suggest using balanced crystalloids instead of normal saline for resuscitation. The SMART and SALTED trial supports the use of balanced crystalloids with a network meta-analysis demonstrating decreased mortality with balanced fluids. For adults with sepsis or septic shock, we suggest using albumin in patients who receive large volume of crystalloids. For adults with sepsis or septic shock, we recommend against using starches for resuscitation. For adults with sepsis and septic shock, we suggest against using gelatin for resuscitation. Gelatin has been found to have no clear effect on mortality when compared to normal saline, and is associated with higher risk of renal replacement therapy, anaphylaxis, and also higher cost. For vasoactive agents, for adults with septic shock, we recommend using norepinephrine as the first-line agent over other vasopressors. For adults with septic shock on norepinephrine with inadequate MAP levels, we suggest adding vasopressin instead of escalating the dose of norepinephrine. The early use of vasopressin in combination with norepinephrine may help reduce the adrenergic burden associated with traditional vasoactive agents. For adults with septic shock and inadequate MAP despite norepinephrine and vasopressin, we suggest adding epinephrine. For adults with septic shock, we suggest against using terlipressin. For adults with septic shock and cardiac dysfunction with persistent hypoperfusion despite adequate volume status and arterial BP, we suggest either adding dobutamine to norepinephrine or using epinephrine alone. For adults with septic shock and cardiac dysfunction with persistent hypoperfusion despite adequate volume status and arterial BP, we suggest against using levosimendan. For adults with septic shock, we suggest invasive monitoring of arterial BP over non-invasive monitoring as soon as practical and if resources are available. And for adults with septic shock, we suggest starting vasopressors peripherally to restore MAP rather than delaying initiation until the central venous access is secure. The administration of vasopressors for a short period of time, less than 6 hours in the well-placed peripheral catheter proximal to the antecubital fossa, is unlikely to cause local tissue injury. And the time to initiation of vasopressors is shorter if we use a peripheral access first. There is insufficient evidence to make a recommendation on the use of restrictive versus liberal fluid strategies in the first 24 hours of resuscitation in patients with sepsis and septic shock who still have signs of hypoperfusion and volume depletion after the initial resuscitation. So this is just a summary of what I have just mentioned. Next, ventilation. There is insufficient evidence to make a recommendation on the use of conservative oxygen targets in adults with sepsis-induced hypoxemic respiratory failure. For adults with sepsis-induced hypoxemic respiratory failure, we suggest the use of high-flow nasal oxygen over NIV. There is insufficient evidence to make a recommendation on the use of NIV in comparison to invasive ventilation for adults with sepsis-induced hypoxemic respiratory failure. So protective ventilation in ARDS. For adults with sepsis-induced ARDS, we recommend using low tidal volume ventilation strategy, 6 mL per kilo, over a high tidal volume strategy. For adults with sepsis-induced severe ARDS, we recommend using an upper limit goal for plateau pressures of 30 centimeter water over higher plateau pressures. And for adults with moderate to severe sepsis-induced ARDS, we suggest using higher peak over lower peak. For adults with sepsis-induced respiratory failure without ARDS, we suggest using low tidal volume as compared to high tidal volume ventilation. For adults with sepsis-induced moderate severe ARDS, we suggest using traditional recruitment maneuvers. And when using recruitment maneuvers, we recommend against using incremental PEEP titration or strategy. For adults with sepsis-induced moderate to severe ARDS, we recommend using prone ventilation for greater than 12 hours daily. For adults with sepsis-induced moderate severe ARDS, we suggest using intermittent neuromuscular blocking agent boluses over continuous infusion. For adults with sepsis-induced severe ARDS, we suggest using veno-venous ECMO when conventional mechanical ventilation fails in experienced centers with the infrastructure in place to support its use. The last part is additional therapies. Steroids for adults with septic shock and an ongoing requirement for vasopressor therapy, we suggest using IV corticosteroids. Since the 2016 guidelines, several large RCTs have been published with a meta-analysis finding faster resolution of shock and increased vasopressor-free days in those receiving systemic steroids. Blood purification for adults with sepsis or septic shock, we suggest against using polymyxin B hemoperfusion. There is insufficient evidence to make a recommendation on the use of other blood purification techniques. For adults with sepsis or septic shock, we recommend using a restrictive over liberal transfusion strategy. For adults with sepsis or septic shock, we suggest against using intravenous immunoglobulins. For adults with sepsis or septic shock, when we have risk factors for GI bleed, we suggest using stress ulcer prophylaxis. VTE prophylaxis. For adults with sepsis or septic shock, we recommend using pharmacologic VTE prophylaxis unless a contraindication to such therapy exists. We recommend using low molecular weight heparin over unfractionated heparin for VTE prophylaxis. And we suggest against using mechanical VTE prophylaxis in addition to pharmacologic prophylaxis over pharmacologic prophylaxis alone. In adults with sepsis or septic shock and AKI, we suggest using continuous or intermittent renal replacement therapy. In adults with sepsis or septic shock and AKI, with no definitive indications for renal replacement therapy, we suggest against using renal replacement therapy. For adults with sepsis or septic shock, we recommend initiating insulin therapy at a glucose level of more than 10 millimoles per liter. For adults with sepsis or septic shock, we suggest against using IV vitamin C. The vitamins trial found no impact on mortality with the regimen of vitamin C, thiamine, and hydrocortisone. And a meta-analysis evaluating high-dose vitamin C also found no mortality impact. For adults with septic shock and hypoperfusion-induced lactic acidemia, we suggest against using sodium bicarbonate therapy to improve hemodynamics or to reduce vasopressor requirements. For adults with septic shock and severe metabolic acidemia, pH less than 7.2 and acute kidney injury, we suggest using sodium bicarbonate therapy. For adult patients with sepsis or septic shock who can be fed enterally, we suggest early, within 72 hours, initiation of enteral nutrition. Early administration of enteral nutrition has advantages like maintaining of gut integrity, prevention of intestinal permeability, and reduction of insulin resistance. So these are my references, mainly from the SCCM website. Thank you.
Siapa yang pesan? Tak tahu. You lah. Hah? Saya belum presentation. Masuk dalam ni. WhatsApp lah. WhatsApp. Sekejap ni. WhatsApp. Oh, tutup dah malam. Macam ni.
practical, semalam saya forward satu artikel yang agak panjang kan. Tapi bila saya kembali ke sebenarnya, dia sebenarnya 8 page je, 7 page yang kita ada. Okay, so tak adalah panjang. Okay, saya macam baca first page saya tengok, boleh buka tapi okay, ada lah. Okay, so in terms of hospitalization again, preventing hypoxia is as important as preventing hypoxia. Okay, so janganlah kita patient oxygenation or PO2 190. Okay, good. Leave it like that. No. Okay, we tighten it down because we know that hypoxia is not good. Okay, right. Satu lagi tadi yang Yana mention pasal extended infusion antibiotics. Betul Yana? Okay. So macam apa yang kita nak buat tu sebenarnya? What does it mean? If I'm not mistaken in this one, I think siapa dah buat ICU, sorry, dah buat ICU dulu lagi, sebaik. Waktu dekat ICU, choice lah, yang dorang prefer to extend the spectrum, beta-lactam sepsis semua, extended duration antibiotic, sepsis punya beta-lactam base lah, especially if dia tak dosing. So instead of they give it over, slow bolus ataupun short infusion, dia give over extended period, sometimes up to 3, sometimes up to 4 hours, ada sampai 8 hours. Okay, why this what it is? Because orang cakap tu beta-lactam antibiotics ni dia punya effect of anti-microbial is when there is better as compared to bolus. Kenapa? Bila bolus tu dia ada that period in which the blood is free of antibiotic. Okay, so because bolus go down there. Okay, so with beta-lactam, kalau you maintain it over a sustained level, pada found that actually the antimicrobial effect is better lah. So ini something yang kita boleh incorporate bila kita nak hospital dosing, kita boleh adjust dengan pharmacist how to do it lah. Okay. Oh, kita ada satu lagi presentation.
Every patient we have to care it for you as well. Jangan just follow saya nak bagi so kalau patient you ada satu habis.
The problem in the difficult part will be identifying the patient. It's easy to get someone who's hypertensive. Hypertensive to a lot of stuff. Screening tools. For instance, news calls. So, comparison between first and more difference. Q4 it's more sensitive and less specific. This factor is more sensitive and less specific. Nah, good thing, maksudnya dia ada kebaikan dan keburukan. Misalnya kalau Q4 more than 2, dia kata okay, high risk mortality, high patient requires ICU admission. So the Q4 mortality is 4%. Tambah negatif tadi 40%. And tapi kalau search criteria is specific capacity, so everything under the sun can have search more than 2. Trauma, 2, tapi kalau we talk about sepsis, kalau saya kalau search criteria dia menyatakan patient ni lower risk of sepsis and lower risk of very good. Dalam tahun kita ada kita ada berapa banyak screening tu sebelumnya sorry. Department kita ada berapa banyak screening tu yang kita empat. Ada empat lagi. Satu, search criteria, choose so far. News tu, kita ada news tu lah. News tu, reason why kenapa kita ada news tu lah sebab kita nak stratify patient dan kita ada level of nanti mau stratify patient. Tahu sama patient require science patient ataupun level of monitoring. Satu lagi. Isi perut korang lah. Korang rasa just start. Oh ni rasa sepsis. Semua sepsis. Just start. Kalau korang rasa oh iya ni sepsis ni rasa bau macam sepsis. Korang lawan layan. But pada medis kita ada 3 yang ni yang kita boleh pakai dalam tahun. And Q so far search pada dalam otak kita ataupun dalam kita yang kita satu lagi adalah news to score ada dalam sistem. Saya dah create dalam sistem. Tapi kenapa satu untuk nak determine whether patient require science admission atau tidak. Tahu sama ada patient ni insepsis atau tidak, kalau score dia more than 5. Satu lagi adalah sekiranya dan satu lagi adalah level of monitoring. Kita nak monitor selama sama ke, monitor every 4 hours ke, monitor every hour ke, ataupun continuous monitor. So nanti tengoklah dalam punya note tu kan, ada apa news to score.
For this because we heard the field so far mentioned by the member and those to just to check. Anyone still remember what are the components so far? You want to screen today, but some of the temperature.
Today I'll be presenting endostic injury. The most common form of injuries among healthcare workers are endostic injuries. In Malaysia, the Occupational Health Unit in the Ministry of Health have reported an incidence rate of 4.7 endostic injuries per 1,000 healthcare workers in 2005. NIOSH 1999 reported that the rate of hepatitis B virus transmission to susceptible healthcare worker ranges from 6% to 30% after a single endostic exposure to a hepatitis B virus infection. CDC 1999 state that average of risk of HIV infection post-endostic exposure to HIV infected blood is 0.3% or 1 in 300. Healthcare workers are the person whose activities involve contact with patients or with blood or other body fluid from patients in a healthcare laboratory or public safety setting. The exposure, there are 2 types of exposure. One is percutaneous and mucocutaneous. Percutaneous is whereby the skin is cut or penetrated by the needles of other sharp instruments, for example, scalpel blade, trocar, bone fragments, or tooth. Mucocutaneous is whereby blood or other body fluids contaminate the eye, inside of the nose or mouth, or an area of non-intact skin. How does it occur? By usually is capping a needle, not using blood taking kit or trolley, holding uncapped needle while walking, assistant doctors during procedures, overflow sharp pin with needle pointed up when doing procedure, needle in places other than sharp pins. Needle stick injury is preventable. Usually, the primary objective is exposure prevention. All healthcare should be informed, educated, and trained on the following: the possible risks of and prevention of blood-borne infections after an occupational exposure, the measures needed to prevent blood-borne pathogen exposure, HPV vaccination, the principles of post-exposure management, and the importance of seeking immediate advice following any occupational exposure. These are the management of the occupational exposure to HIV, hepatitis B, and hepatitis C virus among healthcare workers. The first step is usually immediate action after exposure. The second step is notification, documentation, and referral. Third step is risk assessment of the injury, source, and exposed healthcare worker. And the fourth is management of the exposed healthcare worker. The first will be immediate action. What should we do after the exposure? Usually, express the blood out by squeezing the tissue adjacent to the wound and immediately washing it in water and soap. If necessary, the wound should be disinfected and dressed. These are the flow chart for the management in our hospital for sharp and splash injury. This is the in-depth one. Usually, after the affected healthcare worker occurs, as in having sharp and splash injury or any needle stick injury, usually the healthcare worker will need to inform the supervisor. If during the office hour, the supervisor will need to fill out either sharp injury form or splash injury form. And the healthcare worker will need to see the OSH-MO step. The OSH-MO will need to fill out the OSU SIS 2A and 2B form. Investigation needed. Usually the healthcare worker will be needed to take infective screening and also FPC, RP, LFP in high-risk cases. Usually if the source usually need to take infective screening as well. The OSH-MO will need to inform the PATO-MO. The PATO-MO will need to inform OSH-MO when the result is ready. For after office hour, usually the supervisor on call, usually is PP on call or sister on call, will need to fill out the form. And also the supervisor on call will need to inform ID physician on call. The ID physician on call will need to fill out the OSU SIS 2A form. Then the investigation is the same for the healthcare worker and for the source as well, but the supervisor on call need to inform the PATO-MO on call regarding the blood samples, and the PATO-MO will on call need to inform the ID physician on call when the results are ready. The management of the healthcare worker by the doctor usually depends. Usually the OSH-MO will need to inform the ID physician regarding the case, and also depends on the source, whether is it high risk source or low risk source. If it's high risk source, usually PEP post exposure prophylaxis needed. However, with low risk source, usually no PEP is required. The follow-up is usually, if no PEP required, usually it's 6 weeks, 3 months, and 6 months. If it's PEP required, usually 2 weeks, 4 weeks, 6 weeks, 3 months, and 6 months. This is usually the more detailed one. Usually supervisor on call, like I said, PP, sister or PP on call. After office hours, usually the registered healthcare worker will need to put the names in the triage counter in the emergency department. The blood investigation usually during office hours is usually taken in OSH clinic. If after office hours taken in respective area. The supervisor must acquire verbal consent from source for blood investigation. The blood investigation must be marked as NSI or SI in red and inform PATO-MO in charge of call. Cases seen in OSH clinic will be discussed with ID physician regarding management plan. And for NSI after office hour, healthcare worker and supervisor on call must report the incident to OSH during the next working hour. These are the forms for splash injury and also for the needle stick injury. Next, we need to know the risk assessment based on the 3 criteria. One is the assessment of injury, the second one is assessment of source, and the third is assessment of the exposed healthcare worker. The assessment of the injury usually need to evaluate for its potential to transmit HIV, hepatitis B, and hepatitis C virus based on the type of body substance involved, the route, and the severity of the injury. The type of body substance involved usually are either infectious or non-infectious. The infectious are usually body fluids containing visible blood, semen, vaginal secretion, CSF, synovial fluid, pleural fluid, peritoneal fluid, pericardial fluid, and amniotic fluid. For non-infectious, usually feces, nasal secretions, saliva, sputum, sweat, tears, urine, and mucus. Next will be assessment of the source. We need to make sure the status of the source, whether there is HIV, hepatitis B, and hepatitis C virus status. If the status is unknown, usually a baseline testing will be done immediately. If the source is unknown or cannot be tested, epidemiological assessment for the likelihood of transmission of HIV, hepatitis B, or hepatitis C virus should be considered. Confidentiality of the source person should be maintained at all times. The third will be assessment of the exposed healthcare worker. Healthcare workers should have a baseline testing for HIV, hepatitis B, and hepatitis C virus. The treatment based on the source. If the source is negative, usually we need to just counsel and also did a baseline serological study for the healthcare worker. But if there is source is reduced window period for HIV or hepatitis B, hepatitis C virus, if the source is negative, usually no treatment is needed. But if the source need to refer for follow-up to check for seroconversion, healthcare worker need baseline infective screening for 6 weeks, 3 months, and 6 months. If positive or likely positive HIV, usually we start the EP regime and advise healthcare worker for not to donate blood products, sperm, breast milk, and to have safe sexual practice, and to report for anti-HIV at 6 weeks, 3 months, and 6 months. If the source is positive or likely positive for hepatitis B virus, usually hepatitis B immunoglobulin and hepatitis B vaccination is indicated. You need to administer within 24 hours. And to follow up healthcare worker at 6 weeks, 3 months, and 6 months. If the source is positive or likely positive for hepatitis C virus, usually no prophylaxis is proven to be effective. And just need to advise the healthcare worker to not donate blood products, sperm, breast milk, and also to have safe sexual practice and to follow up as planned 6 weeks, 3 months, and 6 months. These are the recommended PEP for exposure for hepatitis B virus. If the healthcare worker is unvaccinated, usually if the source is positive, we will need to initiate hepatitis B immunoglobulin ×1 and initiate hepatitis B vaccine series. If the source is negative, and also if the source is unknown or not available for testing, usually we need to initiate hepatitis B vaccine series. But if the healthcare worker is previously vaccinated and is known responder, usually if the source is positive or negative, usually no treatment is needed. But if it's known non-responder, if this source is positive, usually we will give hepatitis B immunoglobulin ×1 and initiate the vaccination of hepatitis B immunoglobulin ×2. However, if the source is negative, usually no treatment is needed. But if the source is unknown or not available for testing, usually if high-risk source, we treat it as source is positive. But if its antibody response is unknown, usually we test the healthcare workers anti-HBs. If it's adequate, usually no treatment is required. If it's inadequate, usually we administer the vaccine booster. But if its source is negative, usually no treatment is needed. But if its source is unknown or not available, we also need to test for we also do it the same as positive, whereby we need to test for the anti-HBs. If it's adequate, no treatment is needed. But if it's inadequate, we need to administer vaccine booster and check titer in 1 to 2 months. These are the HIV post exposure prophylaxis. There is 2 types. One is basic and one is expanded. Basic is whereby it depends on the category. Later I will explain to you. The basic, usually the drug regime consists of zidovudine, 300 mg BD, and lamivudine, 150 mg BD, or convivial 1 tablet BD. If it's expanded regime, usually basic regime plus Caletra 3 tablet BD for 28 days. And if Caletra is not available, usually plus indinavir 800 mg BD, ritonavir 100 mg BD for 28 days, or basic regime plus indinavir 800 mg BDS. Next will be the guidelines for HIV PEP. We need to determine the need of HIV Post Exposure prophylaxis after occupational exposure based on the 3 steps. One is to evaluate the exposure, second is to determine the HIV status of the source, and third is to determine the PEP recommendation. First is evaluation of the exposure. We need to know whether is it infectious, any of the source is material blood, bloody fluid, or other potential infectious material, or an instrument contaminated with one of these substances. If yes, usually we need to know what type of exposure, whether is it mucous membrane or skin integrity compromised, in fact skin only, or cutaneous exposure. If mucous membrane or skin integrity compromised, you need to know the volume, whether it's small or large, whether it's few drops or whether it's a major blood splash. And if it's intact skin only, usually no PEP is required. But if it's cutaneous exposure, we need to know the severity, whether it's less severity or more severity. If it's less severity, usually it's like solid needle or superficial scratch. If it's more severe, usually large pore, needle, deep puncture. Next, we need to know the HIV status of the source. If it's HIV negative, usually no PEP is required. But if it's HIV positive, we need to know the exposure, whether it's lower titer or higher titer. If lower titer usually is, example, like asymptomatic or non-low viral load, or high titer means advanced AIDS, primary HIV infection, or high viral load, or low CD4 count. If it's low titer exposure, usually we categorize the HIV positive class 1. If it's high titer, usually we categorize the HIV positive class 2. Next, we need to determine the PEP recommendation. Based on the exposure, if it's less exposure, usually HIV positive class 1, we need to just give a basic 2-drug PEP. But if it's positive class 2, also we need to give an expanded more than 3 drugs PEP. But if the source is unknown, usually no PEP is warranted, but consider basic 2-drug PEP for the source with HIV risk factors. And unknown source as well is the same as source of unknown, whether we also can give consider basic 2-drug PEP. However, if HIV negative, no PEP is warranted. Furthermore, the exposure type is more severe. Usually HIV positive class 1 recommended expanded 3 drugs of PEP. For positive class 2, usually we also give expanded more than 3 drugs of PEP. If the source is unknown, usually the source is unknown or HIV status, usually we consider basic 2-drug PEP for source with HIV risk factor. And HIV negative, no PEP is warranted. So the reference. Thank you.
Thank you for the presentation. Actually, covered most of it already for PY team. I just stumbled about a bit, and then the time is already later. So, any questions before I move on to my presentation? No. So, basically, you can see that actually needle prick injury is very common. And for every year, memang a lot of healthcare workers will have experienced not only once, sometimes twice needle prick injury per year. So, but the thing is, studies also shows that not all healthcare workers took the PEP against HIV or AIDS after the injury. It's less than 10% only they take the PEP for the prophylaxis. So what are the causes? The most common causes actually is manipulating needle in patients, which is 27%, based on one of the research that already done. So what's the risk of the infection following the significant percutaneous injury? Approximately for hepatitis B is 30%, which is 3 in 10. Hepatitis C is 3%, 3 in 100, and also HIV is 0.3%, 3 in 1,000. So, but the risk of hepatitis B and HIV infection is significantly reduced by immunization against hepatitis B and the use of PP. So actually, to summarize everything, the most important 4 factors that we use to determine whether it's very high risk or not, to increase the risk of occupationally acquired bloodborne virus infection is: 1 is deep injury, 1 is visible blood on the device which caused the injury, injury with a needle which has been placed in donor's artery or vein, and also high viral load, as mentioned before, for the HIV patients, especially in advanced stage or undiagnosed HIV infection. So this one I think already mentioned before. Initial management, first aid have to be carried out, and remember, scrubs and antiseptic should not be used. Just normal soap and also water should be used only. But how to say, when there's a risk, when there's a needle prick injury, it's advised that a baseline sample of clotted venous blood in serum gel tube should be obtained from recipient and sent to the microlab to keep with informed consent. Every blood that we send to investigate on hepatitis B, HIV, and hepatitis C, all should take consent from the patients also. So just now mentioned about hepatitis B and also HIV. We talked a bit about hepatitis C. So only lately, hepatitis C has become great concern among the nurses and also healthcare workers. So what hepatitis C can cause is liver failure and liver cancer later on. So in US, hepatitis C can lead to liver failure and liver cancer, and it's a leading cause of liver transplant in US. So hepatitis C most common is by chronic bloodborne infection, and also CDC estimate almost 4 million Americans are infected with hepatitis C. So it's very common over there. And actually, there's no approved PEP or vaccine for hepatitis C. The treatment is basically interferon monotherapy or combination therapy with ribavirin and other current treatments. So hierarchy of controls is basically, as what we say, prevention is better than cure. So what we need is proper PPE, work practice control, administrative control, and engineering control. Actually, engineering control, there's actually new needles that can be retracted and shift or plunge immediately after use one. But so far, Malaysia doesn't have it yet. And elimination of hazard. Okay, very short one. Okay, thank you. Any questions?
Any questions on the floor? Any questions?
Kalau boleh, sebab kita usually akan ada master parking presentation, presentation kan. So I inform before, kalau boleh kita coordinate our presentation so that the second person presenting tak overlap dengan first person punya topics lah. You guys can always talk to each other. But kerja satu department kan. So boleh coordinate je, tanya je lah you present apa. Ataupun kalau you don't present this part, then present this part in depth. So that nanti dia overlap, dia akan nampak macam satu tu dia akan jadi boring. Second tu nanti kalau information tu contradict each other. So itu yang lebih bahaya lah bila information tu contradict each other. With regards to NSI, siapa pernah kena NSI kat sini? Okay. Kalau tak pernah kena NSI tu mesti dia tak cukup prosedur dia. So if you ask what's the best way of treating NSI? The best way of treating NSI is preventing NSI from happening. So taking it to the floor level, making it more practical, yang saya perasan, kita selalu bawa lactating tray, which is good. Tapi dalam cubicle tak ada apa, tak ada syabdi. So bawa lah tray tu keluar, peganglah syringe dengan needle tu pun macam tu. This is very dangerous, kan? Especially in the midst of hypo of resuscitation. Okay, sharps yang dah guna tapi tak immediately discard will become problematic, kan? Sebab you rely on the patient state just like that. Lepas tu this people want to grab this thing, this people want to grab that thing, senang dia akan use NSI. Lepas tu tak tahu lah nak marah siapa, kan? Sebab dah jadi, kan? Second thing is criteria of patient yang kita nak buat procedure, macam siapa yang dapat di ultrasound vascular, ultrasound vascular exams. Kita baru buat recently ni. The choice of patient is very important. Maksudnya kalau patient tu is restless, okay, don't even choose the patient to insert CDI lah. Unless kalau kita boleh sedikit dia patient. Okay, because that one will be very dangerous for the patient, will be very dangerous for you. Dangerous for you in terms of NSI lah. You poking yourself after poking the patient. Yeah. Other than that, always inform kalau you nak buang sharp. Okay. Atau you nak carry sharp. Especially kalau you are in a cubicle with your mates. Okay. I'm throwing the sharp, don't move. Okay, sebab tu orang bergerak macam tu, kan. So bergerak macam tu, seorang yang tengah pegang sharp tu, I dah dengar lah. Apa? Dulu kan kita ada ketil tu, kan. So member daripada belakang bawa needle macam tu, I dekat belakang, I tak tahu kalau dekat belakang tu dekat ketil tu, okay. Masih baik tak interest lah, okay saja. Okay. Second thing is, make sure you punya Hep B immunization antibody titer tu, very correct. I think kita selalu check, kan. So that one is very important lah. Ada tanda tu, ada yang you mention tu, identifying injuries at risk of NSI tu is very important. So maksudnya what are the types of injuries yang if it happens, you are at risk of NSI lah. Okay? The NSI can happen pre, intra, post procedure, kan. So the highest is intra and also post procedure lah. Okay? So maksudnya identify kalau you punya follow-on needle you ada blood, and then equipment tu dah pernah guna untuk patient. Apa lagi? It's a very big wound instead of a small wound. Satu lagi yang kita jarang nak perasan ni sebab kita nak depends on antibody, viral load tu is actually dah retrospective, kan. Identify patient at high risk. Betul macam kita tengok patient tu ada history of IBU from history tapi tak pernah buat HIV testing lagi. And then you tengok dia jaundice. Oh my god, mesti dah at least Hep B, Hep C. Betul. Bukan mulut cik, banyak gila candida, kan, confirm HIV. Okay? So clinical part of it, clinical identification of patient at high risk of you getting NSI itu is very important, kan, instead of you depend on viral load sahaja. Especially identify you punya AIDS defining disease, kan. So kalau kita dah macam tu, kita akan lebih be more careful lah. Wearing gloves won't protect you from NSI, okay? Dia akan protect you from cutaneous exposure sajalah. Okay? Kalau dekat university tu ada some raw, dia akan protect. Tapi kalau pakai glove, kan, boleh go to juga, kan, bukan pakai glove besi, kan. Glove ketat saja, okay? So still be very careful lah. Although you wear glove, that does not mean you will not be exposed to NSI. NSI can happen anytime, anywhere. Okay? Lagi-lagi tengah malam, bila jangan ngantuk kot kita, kan. Saya rasa itu sahaja. This one is very favorite topic untuk master dan FRCAM ini in terms of counseling station.
Saya cuma nak share a few points tentang PowerPoint presentation. Okay, so bila kita buat CMP ini, it is actually an opportunity for each and every one of you to practice on preparation and also presentation skills. Especially those yang taking exams and going to be specialists, not only you will be presenting in the national and international level. So this is a chance for you to practice. So dalam PowerPoint presentation, you should not be putting a lot of sentences dalam the slides. Okay, avoid putting sentences yang mana you yourself can read from the slides and then your audience can read from the slides. Jangan buat macam tu. If you put points yang you tahu kata you want the audience to take home, you just put the points on the slides. And then whatever sentences ataupun benda-benda yang you nak say to the audience, you can put it in the presenter notes. And PowerPoint pun nanti ada presentation so you just write it down piece of paper and then if you cannot remember, you will just it. But avoid putting sentences. And then kalau it is going to be more interesting, kalau you boleh letak diagrams ataupun apa ni pictorial punya apa ni presentations kan, maknanya benda-benda yang dalam bentuk ayat tapi you buat dalam bentuk gambar kan, so the audience can capture that and you can remember and read it home. And then selalu last tapi you always put on the slides take home the points. What are the things that you want the audience to take home from your presentation? And it habiskan dengan that last slide. You summarize it so that bila di slide apa yang presentation habis, you know that the audience took something from it. Okay. All the actors then this one was very big. You just need a little bit of touch up and something emergency. Great effort.
Sebelum itu bersuara, tadi COVID kita dua staff baru. Nama akan dulu yang pertama adalah Occupational.
I am a pre-hospital care fellow and I will be here for about 3 months. Hello everyone, I'm Marisha from Untitled Chapter. So I'm joining the questions.
Sebagai tambahan, bagus, presentation bagus, cuma nanti kita tidak keluarkan coding secara dalam. Macam lagi, jadi kalau ada siapa yang nak bertanya tentang sepsis, boleh tanya kurang. Kalau siapa yang tanya tentang sepsis, impeach, boleh tanya Dr. Sabihan belakang.